Welcome back, our fans. Management of patients with liver diseases. Liver functions. 1. Metabolism of A. Carbohydrates. Extra glucose is stored as glycogen. B. Proteins. Unneeded amino acids are broken down into ammonia and the liver metabolizes ammonia into urea. C. Fats. Lipids are broken into very low density lipoproteins, VLDL. D. Drugs. Processes certain drugs and detoxify it. Local anesthetics, analgesics, sedatives, antibacterials, and antifungals are all metabolized in the liver. 2. Synthesis of A. Bile. When the RBCs break down, hemoglobin is broken into hemoglobin. The heme part is processed by the liver into bilirubin, yellow pigment, and excreted in bile. B. Proteins. The amino acids are used to form albumin, transport protein. Clotting factors, vitamin K dependent, factors 2, 7, 9, 10. Proteins of the complement system, important for immune reaction. 3. Storage of vitamins and minerals as iron. Laboratory investigations. In liver disease. A. Higher levels of prothrombin time, PT, and international normalizing ratio, INR. Liver enzymes, alanine aminotransferase, ALT, and aspartate aminotransferase, AST. A. Lower levels of albumin. Urea. Liver diseases. The liver diseases may be caused by infections, as viral hepatitis, alcoholism, toxicity, autoimmune disease or cancer. Liver cirrhosis. The diseased liver cells try to heal by fibrosis, affecting the overall function of the liver. This cirrhosis may cause increased resistance to flow of bilirubin to the bile duct, causes its higher level in blood, hyperbilirubinemia. It manifests as yellow discoloration of skin, mucous membranes and sclera of the eye, jaundice. Portal blood and causes portal hypertension. This causes back pressure on the spleen, increasing the breakdown of platelets, thrombocytopenia. If the patient was not treated, the condition will progress till the liver fails to perform its functions completely, liver failure. If untreated, liver cancer. General manifestations. 1. Start as asymptomatic. 2. Increased bleeding tendency due to lower rate of platelet synthesis. Higher rate of platelet destruction due to portal hypertension. Lower level of clotting factor synthesis. Increased destruction of fibrin. 3. Anemia, secondary to bleeding from the git, esophageal varices. 4. Jaundice. 5. Clubbing. 6. Cyanosis. 7. Spiderangioma. 8. High levels of ammonia in blood may reach the brain, causing encephalopathy. Oral manifestations. 1. Purpura and gingival bleeding. 2. Jaundice. 3. Symptoms of anemia, pallor and glossitis. 1. Asymptomatic parotid enlargement. 2. Halitosis due to high levels of ammonia in blood. Hepatic fever. A dental patient who has liver disease should be concerned regarding 1. Higher bleeding tendency. Preoperative lab investigation should be performed, platelet count, in CBC, PT and INR. Referral to physician in case of abnormal results for management before dental procedures. 2. Medication prescription. The patient should not take certain drugs as the liver will not be able to detoxify it. Articaine is better used instead of lidocaine. NSAIDs should be avoided. Paracetamol can be used but in low doses. Systemic antifungals, erythromycin and tetracycline should be avoided. Safely used antibiotics, penicillins, cephalexin, cefazolin, and minocycline. 3. Avoid supine position in patients having ascites. 4. Patients who performed liver transplant are immunosuppressed. Extra special considerations with patients having viral hepatitis. 1.
Possibility of cross-infection in cases of hepatitis B, C and D viruses.
Precautions should be employed. 2. HCV-associated oral lichen planus, OLP. OLP is associated with HCV. So, when OLP is detected in a patient, HCV-AB test should be performed to exclude the presence of an undiagnosed HCV. Management of patients with kidney diseases. Kidney, renal, functions. 1. Filtration of blood and excretion of metabolic end products. A. Ammonia and urea. B. Creatinine. C. Uric acid. D. Drugs and toxins. 2. Reabsorbing useful components from urine back to the blood, as water, salts and calcium. 3. Activates vitamin D. 4. Secretes erythropoietin to control synthesis of RBCs. 5. Participate in control of blood pressure through secretion of renin. Renin then activates angiotensin to cause vasoconstriction. Chronic renal disease. Mainly caused by diabetes and hypertension. 1. Salt and water retention, hypertension that progresses to cause heart failure. 2. Low levels of erythropoietin, anemia. 3. Uncontrolled loss of calcium, 2-Ry and 3-Ry hyperparathyroidism, renal osteodystrophy. 4. High level of urea in blood affects function of platelets and clotting factors, uremic bleeding. 5. Uremic toxins affect cellular immunity, higher susceptibility to infections. 6. Electrolyte imbalance. Middle dot. If untreated, the disease progresses till the kidney fails to perform its functions completely, renal failure. Treatment. 1. Medications as antihypertensives, calcium channel blockers, and cyclosporin. 2. Renal dialysis with anticoagulants. 3. Renal transplant. Oral manifestations. 1. Xerostomia. 2. Metallic taste. 3. Halitosis. 4. Purpura. 5. Candidosis. 6. Uremic stomatitis, ulcers, erythema, hemorrhage or hyperkeratosis due to uremia. 7. Oral hairy leukoplakia. 8. Periodontitis. 9. Drug-induced gingival enlargement. 10. Bone lesions. Dental management of a patient having chronic kidney disease. 1. Supine position may not be tolerated by the patient. 2. Bleeding. A. Blood tests, CBC and coagulation tests. B. Communicate with nephrologists before invasive dental procedures to discuss the possible risk of excessive bleeding or when INR is higher than 3.5. C. Then, bleeding should be controlled by local hemostatic measures. 3. For candidosis, periodontitis and dental caries. A. Daily use of 0.12% chlorhexidine mouthwash to minimize the risk of a fungal infection or A. Topical fluoride therapy in patients with high caries risk, but not systemic fluoride due to its nephrotoxicity. 2. For halitosis and xerostomia. A. Chewing gum and artificial saliva. B. Strict plaque control. 3. Patients of renal failure are prone to bacteremia and infective endocarditis. So, antibiotic prophylaxis is indicated before invasive dental procedures. The type of the safe non-nephrotoxic antibiotic should be decided with the physician. 4. Nephrotoxic drugs should be avoided, NSAIDs and aspirin. Low doses of paracetamol are preferred. Local anesthesia is used safely but with restriction of the dose of epinephrine containing LA due to hypertension. Safe antibiotics azithromycin, minocycline, doxycycline and metronidazole. 5. In patients performing dialysis. A. Dental procedures should be made on the day after dialysis to benefit of the lowest level of uremic toxins and when the effective heparin has ended, after 6 hours of dialysis. B. They are at high risk of bloodborne infections as HIV, HBV and HCV. 6. In patients receiving transplant. Before transplant, treat any infection, remove any septic focus and maintain oral health. 0 to 6 months after transplant, emergency treatment only in hospital environment. More than 6 months after transplant, usual treatment based on nephrologist's instructions. Thanks for watching. Support us by likes and subscribes.